So good morning, everyone. And thank you, Dr. Himadri, for the invitation. And I'll try to play the devil's advocate here, talking against scleral buckling a bit. So why not moving? Okay. Right. So I'll be talking about why it has fallen out of vogue, and vitrectomy has come a long way. In 1927, Lister was quoted as saying that these surgeries should be tried as a last clutch at a last straw of hope. But we are living in the age of sutureless. The residency programs these days, there's hardly any exposure to sutures. So we are more into phacos and small incision surgeries. So the residents, the new trainees are a little afraid of sutures. So, and of course, as we have seen, buckle involves a lot of suturing. The vitrectomy has evolved itself a lot. From moving from 20 gauge to the 27 gauge, it has become very advanced, and sadly, the buckling procedure has, a lot of people feel, has nothing new to offer over the years. And these smaller gauge vitrectomies permits the surgeon to work really close to the retina, and with a lot of safety as well these days. We feel that there is extensive tissue trauma while doing these surgeries as compared to a vitrectomy surgery. So you'll have cleaner eyes and more comfortable patients post-operatively. And we have, most of the times, we can achieve a complete attachment at the conclusion of the surgery, which might not be the case in case of a buckle. And you might have better visual outcomes immediate post-operative period. It gives you an edge while you are locating breaks with the viewing systems that we have these days. Then you have always the option of a drainage retinotomy, where you can flatten out the retina and have a good attachment on the table. Oops. And of course, for very complicated RDs, we would prefer a vitrectomy. We have seen certain cases which Dr. Himadri showed today. He has attempted in these cases and had got really good results. And we have the option of doing a 360-degree laser, which will take care of all the missed breaks that you have. At times, you would feel that a lot of are of the perception that buckling would take a lot of time, and a good simple vitrectomy you can even wrap up in 40-45 minutes. So probably less surgical time is also there. And as we were discussing after Dr. Himadri's presentation, it requires a very thorough pre-op evaluation, which is an art that we are losing these days. There are certain complications specific to buckling that are always there. We'll not go into these details, but again, vitrectomy is also not complication-free, but we are also have to take these complications into consideration. The basic point of this presentation was to incite a discussion about why the young retina surgeons these days are afraid of this procedure, and it is slowly it's going out of practice. Personally, in my practice, it constitutes less than 20% of my cases, which is exact opposite of what Dr. Himadri told. So he's operating almost 80% cases with a buckle. Discussion is up to you, Dr. Himadri. Yeah.
We do not have much time for discussion, but one thing I'd like to mention is that vitrectomy or any retinal surgery, as we have spoken earlier as well, they are prone to a lot of errors, and they tend to be very unforgiving. You do a little mistake and you will end up with a redetachment, with PVR, everything. But my own experience, on the other hand, with scleral buckling has been very good. It tends to be very forgiving. Even if you have not completely buckled, even if there is a little bit of a mismatch in the buckle and the break, retinal tends to settle down over a period of time. Right. And incidentally, I did a little bit of study about the previous generation papers and found that there was a time when actually a minimal scleral buckling used to be offered, where they would actually not do cryo, just put in a buckle on the break and leave it. No drainage, nothing. And even those patients, they had a long case series where those patients would do really well, even when you compared with the cryo. So in my own experience, I have found that buckling to be very forgiving surgery, and over a period of time, you can actually wait and see the fluid disappear and the retina settle down.
Very valid points. So, few words from you, last words, sir and Naresh sir. So, about what we can do to encourage young fellows and residents to take up this surgery in the future.
The only thing is the buckle, make the buckle that some financial.
We can't hear sir properly. Can you?
No, like you can make the buckles with platinum so that it has got some financial value. Come with some rare element because buckle costs you hardly 1,000 rupees, no financial interest is there.
Right.
That is one of the reasons. And second thing, I think, so my teacher used to say, Dr. PN, a great buckler, the time you spend inside the theater should be shorter than the time you spend outside the theater. So that is not happening today because you'll have to work for at least 45-50 minutes to search all the breaks. So I think that inherent laziness might be one of the reasons, but as discussed by every one of you, it's a wonderful art actually, especially for children. If it is on day one, it is going to be on ever. It's as simple as that.
Thank you so much, sir.